Hi all, welcome to ATC. So today we have Dr. Riaz presenting a neonatology case, a 2-month-old case, presented to RED like 2 days before. Over to Dr. V and Dr. Riaz.
Thank you, sir. Sir, a 2-month-old baby was brought here with a short history from the EMT that the child is having severe multiple episodes of vomiting for the past 24 hours, and now the child has become very drowsy and they have brought immediately to the ER. So in my initial 10-second assessment, I just immediately did our PAT triangle, sir. In the PAT triangle, the child was appearance-wise has become, the patient's tone was very flaccid, and there is very less intractability and no response to my any stimulus, sir. And when work of breathing, the child was almost apneic and gasping state, sir. And the circulation part, there were mottling in the thigh region and the various skin parts, sir. And immediately checked the CRT, but CRT around 2 to 3 seconds prolonged CRT was there. So it was my initial PAT track assessment. So immediately I did my primary survey, sir. In the primary survey itself, I asked the staff to, it was a parallel survey, to immediately secure.
Since you have done your PAT triangle, there should be some sort of physiological intervention to be done at that point of time, isn't it?
Yes, sir.
So what was done at that moment of
In
time?
PAT triangle, it looked like that the child is having some amount of respiratory distress along with the severe dehydration. So immediately actually I started the supporting the ventilation with an ambu bag support was given, sir. And in the primary survey only I got the vitals. Anyway, in the PAT triangle itself I started giving support with an ambu bag, and along with I asked the staff to immediately secure an IV line and to give a fluid bolus of around 20 ml per kg. The child's body was around 5 kg. 20 ml per kg of IV crystalloids were asked to given as a bolus after securing the IV line. This was my initial instruction. Then I started doing my primary surveys.
So what was the physiological impression at that moment of time?
One is that since from the history I thought that probably because of severe vomiting, the child has gone into severe dehydration and into severe dehydration induced some acidosis or fatigue, sir.
Okay, so the child presented you with gasping, isn't it?
No, almost gasping, sir.
Gasping. So it could be either a respiratory cause or metabolic cause again.
Yes, sir.
We don't know what exactly
we don't know the
cause.
exact cause, sir.
So you have basically secured the airway. Have you secured the airway?
No,
you
sir.
Supported assisted breathing.
Yeah, started supporting the assisted breathing, and I just want to do the primary service.
And then you have to give IV fluids also.
Yes, sir. So in the PAT triangle itself, I have asked these 2 orders to be immediately done.
Okay. For a 2-month-old child, what is the probable IV cannula size you can use?
Sir, either 22 or 24 will be ideal, sir.
Okay. Where did you use it?
Actually, even though I asked the staff to do, they attempted to all the different peripheral sites, but they were not able to secure the IV line. So by the time, since they were unable to secure the IV lines, immediately I asked for an intra-osseous access, and we were able to place an intra-osseous access to the left proximal tibia side. And from the box, once the intraosseous access has been achieved, we were able to give IV crystalloid bolus through the intraosseous access.
Okay, Dr. Manna, tell me what's the criteria for securing IO access?
IO access usually if more than if by an experienced person, if more than 2 attempts of IV access fails, then we'll go for an IO access.
Okay, so what about what are the drugs which can be given through IO access?
IO access, actually every drugs can be given except for some anesthesia drugs cannot be given, and adenosine also doesn't have any, will not produce a optimum metabolism.
The question is, can you give PRBC through IO access?
Yes, sir.
Yes, sir.
Okay, good. Correct.
So that was run in parallel itself, and in my initial primary survey itself, the airway is actually patent, sir. No oral secretion, there was no tongue fall, and cervical spine was also within normal limit, and so airway was appearing patent at that time, but breathing, the air entry was reduced on both sides, sir, and saturation was maintaining around 85. Actually, saturation was maintaining 99. Even the child was brought in an ambulance, and they were already giving an oxygen by the face mask, sir. And the oxygen, so we were just continuing that oxygen, so the saturation was maintaining around 99%, even though the patient is having severe bradypnea. Then immediately, since there is severe respiratory distress, I asked when they as an EBG at that time itself. Then I parallelly surveyed for the circulation. Already in the PAT triangle itself, we have somehow secured the intraosseous access, and I connected the chest leads, and we were able to see that heart rate was around 140s, and the BP, the CRT is there, and the systolic BP with our NIBP cuff, it was not detectable. but the peripheral CRT was around 2 to 3 seconds, sir. That was the initial circulation. But so anyway, we have asked given for a fluid bolus. Post fluid bolus, they actually the CRT improved, sir. It was less than 2 seconds. So since we are expecting severe dehydration, I asked for a maintenance fluid at that point itself with the Holiday Agar formula, 4 ml per kg. So around 20 ml of IV crystalloids. Maintenance fluid was also asked at that point in time. So then I went to the disability. Disability is the sensorium is still low, sir. GCS is around only maintaining around E1, V2, V1, M3. Hardly that's the GCS, but people was 2.5 mm bilaterally reactive. I immediately checked the GRBS also. GRBS was around the 200, sir. So in view of this primary survey and exposure, peripheries were warm, cold, sir. Peripheries were cold with mottling were detected. Was post fluid resuscitation actually, but the mottling was gradually resolving. So anyway, in the initial in primary survey impression of the patient is having very low GCS with severe impending apnea and impending respiratory failure. I proceeded with going with an elective intubation, sir. So by that we planned for an rapid sequence intubation for the baby, and for that actually we were properly already we were giving oxygen, and the child was maintaining the saturation of around 99 to 100. So we gave we chose the baby and a blade size of around 1 size, and that is Miller straight blade was used, was preferred, and hardly baby was 5 kg with the 2 months old. So we selected the tube of around 3 sized uncuffed tube was selected, and we compared with the size with the little finger, and it was almost matching, sir. So we with the backup of around a small size of around 2.5 and 3.5 to ET tube was also kept ready, sir. And along with drugs we opted where that we gave a short for analgesic we preferred fentanyl only, 1 microgram per kg, and drugs we opted where for induction ethomidate was preferred, and so I took 0.3 mg per kg of ethomidate, and for muscle relaxation rocuronium was I used rocuronium 1.9 to 1 mg per kg was used, sir. So with these drugs we gave analgesic, and for a backup, even though the heart rate is maintaining 140, there are high chance of child going into bradycardia while we try to intubate. We kept a backup of atropine also 0.02 mg per kg.
Can you substantiate your point of you going with ventilation this part of survey? Why you have to go for ventilation?
Oh, one is that the child is having severe respiratory bradypnea, sir, and one thing is the patient is having severe low GCS, sir, and second is that by the time actually already I have asked for the ABG, sir, adjunct to the ABG primary survey, but the ABG results also I got. ABG was showing severe respiratory, severe metabolic acidosis or pH of around 6.7, sir, with lactate more than 20 bicarbo 4, sir.
Okay, Dr. Vivek, suppose you are working in a tertiary care setup outside this hospital, and you want to transport this baby to a hospital, maybe like around 50 km away from your main hospital. So would you transport this baby like this with an O2 mask?
Yes, sir. It is not advisable to shift with O2 mask, sir. Better to secure airway, then shift the child, sir. And if possible, with the accompanying doctor who can manage those emergencies in while transport, sir.
Okay. Is there anything else to be done in that part? Do you have to give any sort of overs to the other hospital or to the other doctor?
Before shifting such a patient, we have to inform the receiving hospital and make sure that patient had there should not be delay in taking the patient in or while shifting to intensive care unit, sir.
So what about if this baby has come to the ER with a severe head trauma? I suppose it will be almost similar to this presentation with bradypnea, maybe some sort of herniation is there, and the baby has come just like that without any sort of assistance to the airway, and you have to go for imaging purpose. Would you still shift with after ventilation or prior ventilation, and why?
Sir, child is having head trauma, now sensorium is low, secure airway, then only shift for neuroimaging, sir.
Why?
Sir, our assessment starts with airway, breathing and circulation.
Okay.
In such a patient with low sensorium, we don't know how long baby will sustain this respiratory efforts. If we shift and airway is not secure, there is chance of respiratory arrest is possible.
Okay.
So
indirectly, what you are saying is the most common cause of arrest in a pediatric case is always hypoxia. Hypoxia, hypotension, and hypoglycemia. These are the three most common causes which results in pediatric arrest. So always you secure the airway and then move with any any procedures and nothing, right?
Any thermoregulation part you will have to keep in mind.
Yes, sir.
From
Baby
the
is
beginning,
Going,
Soon the
into,
patient is being
hypothermia.
received, you should not forget this one also.
We
Okay.
have a proper blanket to cover the entire
Okay.
body. Sir.
Good.
Okay, so what are the differences between a pediatric airway and adult airway?
Sir, there are many differences. One thing is that when we are planning for a pediatric airway, we should also always anticipate that the circumference of the baby's head will be more, the occiput prominence will be more, sir. So when we are going with a pediatric intubation, better to keep a 1-inch pad of towel or some thickness, so that the shoulder in between the shoulder blades, so that the airway becomes almost in a straight line. Second thing, that in pediatric airway, the tongue size of the tongue will be compared to the oral mouth cavity will be more proportionately large, sir. The third thing is that the shape of the epiglottis itself, it is a more of an omega and floppy shape in case of pediatric. And thing is that the larynx, it will be itself will be funnel shaped, sir. And one thing is that, and another thing is that in adults the vocal cords are more of perpendicular, while in pediatric it is more of angulated. And next thing is that when in adults you have to use a cuffed ET tube, but in pediatric age group, in uncuffed tube, the cricord itself will act as a cuff, sir, for using the pediatrics. In the this is a major difference between the pediatric and adult airways.
Okay, so what is the ET tube size which you use for a newborn and followed by till 2 years?
Sir, the least available size in our hospital is from 2.5 uncuffed ET tube size, sir. So for a newborn, we will have to use from 2.5 or from 3 up to 3.5. This will be the ideal size, sir. So once the patient becomes, as you said, sir, after 1 year or 2 years, we can use the formula like age by 4 plus 4 for an uncuffed ET tube, or age by 4 plus 3.5 for a cuffed ET tubes and be used, sir. For in case sometimes there can be the formula cannot be properly applied, at that time we can just compare the anatomically with this size of our little finger. It will be almost equivalent to the size of our vocal cords.
How
So
do you determine the blade size?
Blade size, so anatomically we can measure, we can just ideally we for infants less than 1 year we will probably go for a Miller straight blade, sir, and adults we will be going for a Macintosh curved blade will be used. In Miller straight blade itself, we can size can be determined from the tip of incisor to the angle of a mandible. That length can be taken for taking the proper size of the blade, sir.
Fine. Describe the intubation purpose and the intubation procedure in this case.
For this child, the intubation is reason for intubation is low GCS and severe metabolic acidosis, and to prevent the impending cardiac failure, we are selectively intubating this child before going into complete arrest, sir. And stepwise it is that we have already pre-oxygenating the child, and for pre-medication we are giving an analgesics, already mentioned fentanyl, and for induction we are giving ethomidate, and we should always keep the backup all the suction our backup plus or minus 1 size of the ET tube, and in case of an emergency, backup anesthesia on call should be informed in case we have a failed attempt of an intubation. And as a bougie, pediatric bougie is also available in our hospital. That probably we have a stillet. We will be keeping everything ready, and with the proper suctioning and proper pre-oxygenation, we will use a pediatric ambu bag of tidal volume around 450 to 500 ml. We will be first giving analgesics, followed by antiemetic can be given, sir. And atropine, even though we keep it ready, we give it only if the child is going into a bradycardia. So we keep it ready for our child. For our intubation in this case, we didn't have to use it because child was always maintaining a heart rate above 100. So after giving analgesics and antiemetic, and we gave induction agents. Induction ethomidate was given. After induction, around 3 minutes we will wait. Once the child is already the child was having very low GCS. So after the induction, then I gave for muscle relaxant.
After induction, you will wait for 3 minutes, or?
I mean, usually an ideal patient, if the patient is fully conscious, then we will have to wait for 3 minutes to make sure the
No,
child.
rapid sequence intubation. You told about it. You are planning for rapid sequence intubation.
Yes, sir.
So how it be proceeded by?
Pardon, sir. I mean, we gave we already
Pre-medication for 3 minutes.
Yes, sir.
After that, you start administering. What is meant by rapid sequence intubation?
Because
What is the difference between this and elective or Other intubations?
No, one thing is that one is the patient is completely unprepared in our case, sir, because ideally when elective intubation happens, the patient will be already having an in per order for the past several hours, and the patient we will be knowing the neurological and cardiovascular status of the patient. So we will be using already selecting the drug, knowing all the history, everything we will be anticipating earlier itself, and we can go ahead with the planned procedure.
Okay.
While we in a rapid sequence intubation, we don't know when was the last meal of the child, we don't know what's the cardiovascular status, we don't know the neurological causes. With the short history, we will have to go ahead with the most appropriate drug, and we have to go ahead with the intubation, sir.
Okay.
There is high chance of aspiration, high chance of vomiting, everything will we have to anticipate, sir.
Can you please explain in one sentence what is meant by rapid sequence intubation?
Rapid sequence intubation is that whenever we are planning to go ahead with intubation, even without any preparation for parts, so we anticipate all the complications.
You want to assess the airway?
Yes, sir. We can look for the elements, or immediately can be done, sir.
See, what will be looked for in the airway? Not only for the pediatric, adult also. In the rapid sequence intubation, what the most important thing you have to
for
keep
any
in mind?
possible difficulty in ambuing will be there, like mask or any danger or any jaw injury, anything is there, we have to anticipate earlier itself, sir. And we have to look for the possible short neck patients that we have to expect and difficult intubation, short neck. So this is basically we have to look for the lemon.
What is the advantage of rapid sequence intubation?
Advantage as such, actually.
Why do you want to prefer this method?
Prefer means time is the
No,
only factor.
without any time delay, you want to get a secured airway which is pulled through from the aspiration. This is the main concept about the rapid sequence intubation. So what has to be done? You have to use an induction agent, you have to use a paralytic agent, and other things you will be slowly administered and then wait for, then you can proceed with the paralytic agent. It's a sequential and simultaneous administration of induction agent and muscle relaxation along with analgesic agent whenever necessary. So there should not be any delay of 3 minutes or something like that. Okay, the 3 minutes is the time before starting the induction agent administration. So during which period you will assess the patient and you will pre-oxygenate, all the preparations will be done during this period. Once you start the induction agent, there should not be any delay at all. Because when the patient is going for apnea, so hypoxia will set in. So the quickest means of intubation should be done. So we are giving in a sequential order both induction and paralytic agent. So one contraindication is when you cannot intubate, cannot ventilate. So what you have to do? You have to assess an airway compulsorily to make sure whether we can able to ventilate or we can able to intubate. So if you do not know whether it's a doubt, then what will be the position? Don't give muscle relaxation. That is the most important thing. Okay. Otherwise other things are okay. So this is a sequence and immediate achieving of the patent airway being covered by the aspiration chances avoided. Okay, that's all. Okay. So don't bring this 3 minutes waiting and all. Okay. Then next one. So in this we have to compulsorily assess the airway. So the airway means what are the things you have to assess for?
Oral cavity.
Aside from whether we can able to pass the laryngoscope, there is possibility, mouth opening and other things. Number 2, is there any growth in the way, anything, whether we can able to pass the tube. Suppose it's not possible, what will be the next option? So that also we have to assess. Supraglottic airway devices, whether we can immediately resort to supraglottic airway. So if it also fails, then what you have to do? Then we have to go for cricothyrotomy. Whether is there any growth or any distortion anatomy. So all these things should be pre-hand assessed. Whether it is a rapid sequence intubation or any other type of intubation, it's a must. One of the important steps. Don't forget. Okay, carry on.
Is there any contraindication of needle cricothyrotomy in individuals, in children? Less than 2 years? Yes?
Indicated or not indicated?
Stenosis is yes, sir. The possibility of post-recorded. It's not preferred in pediatric.
Okay.
Anatomical localization will be very difficult.
So post following that we gave muscle relaxants also. After that we were able to electively without with the help of Buji itself we were able to place the 3-sized 82 and we secured the angle of mouth of around 9 between 9 and 10 and we were able to secure and we started doing the aboving and air entry was there bilaterally equal and the ETCAT was showing around 30 sir. The tracing was there. So post intubation we were continuing the IV fluids and we sent for the routine blood investigations and we actually since the bicarb was very low for we gave 1 milliequivalent per kg of soda bicarbonate was also given to prevent the impending cardiac arrest post intubation only and following with the giving.
Why did you specifically say post intubation in that case?
Sir, soda bicarbonate there is a side effect there even though it can be used to neutralize the pH. The soda bicarbonate will immediately dissociate into carbon dioxide and water inside the once it enters into our system. This sudden increase in carbon dioxide can cause into a worsening of the respiratory acidosis also. So already in such patients with poor respiratory complaints and already the patients having severe metabolic acidosis and over burden of respiratory acidosis also happens means the child will definitely go into a cardiac arrest, sir. So always
it doesn't cause exactly respiratory acidosis, it causes intracellular acidosis.
Intracellular acidosis.
Carbon dioxide gets absorbed inside the cells, which in turn causes intracellular acidosis, which in turn gets a pseudo carbon dioxide level value in the ABG. Okay.
So this child once intubated means then we can take over the respiratory system and have a proper adequate ventilation. Then means even though this sudden surge in carbon dioxide always, even if it occurs, we can somehow take it out by the lungs, sir. So always better to give bicarb only after intubation.
Okay.
So following which after this patient once intubation everything was over, we again reassessed the primary survey and then now the air has been secured and breathing is air entry is fine, sir, and we connected to the ventilator with the 6 ml per kg tidal volume and tidal volume was set and we actually connected with this volume control mode, sir. So pressure PEEP was kept as 5 and pressure it was achieving around 14 to 15 with the respiratory rate we kept it around 45, sir. And this with the ratio 1:2 was kept and child post intubation we repeated the ABG after 1 hour. Post 1 hour ABG they actually the pH as well as bicarbonate as well as lactate improved.
Small question. You kept a rate of 45 and I/E ratio of 1:2. Ideally 1:2 ratio, if you keep it exactly, the rate per minute should be around 30, isn't it? So in infants you actually don't require 1:2 because in adults it is 1:2. In like infants they can go up to like around 1:1.5. Moreover, one more thing is the patient is in severe metabolic acidosis. So obviously there will be sort of respiratory alkalos along with that, isn't it? Because there will be washout of carbon dioxide. So obviously it is a bit of higher rate or maybe a higher I/E ratio, which can be tapered down still up to like around 1:1.25 or 1:1.5. Okay, anyways.
So post our initial resuscitation, the ABG everything improved, sir. Then by the time we took the secondary survey also. In the secondary survey, we ample no history of any allergies, no history of any taking any medications. Past history is that the elder sibling of this child also history of neonatal death at the post 2 weeks of birth history is there. But they don't know the exact cause of death of that child also. This child was born, it's a full-time baby, apparently normal and the delivery was, there was no significant incidents. Child was apparently normal at home but child developed having multiple episodes of vomiting in the past 24 hours. Child was taken to a local hospital nearby yesterday and they were given some antiemetic and ORS solutions were given. But in spite of the treatment and these drugs, the child was having continuous vomiting, sir. And when the child started become more drowsy and the sensorium started falling, they have brought the child to the our hospital, sir. That's the history that I got.
So what is the clinical impression at this moment? What is a clinical diagnosis, workup diagnosis?
Workup diagnosis with the relevant past history and all, we should actually suspect any inborn error of any type 1, any errors of metabolism or anything is there also, sir, because our age is showing severe metabolic acidosis, and also the past history of child has been there, and the child was absolutely normal, now gradually has developed, followed by multiple episodes of vomiting that is unexplained, and so we have to rule out any metabolic errors is there in this child, sir.
We can't.
Along with the dehydration also we have to keep in mind, sir.
So your clinical what you're treating is basically it's a hypovolemic shock.
Shock was there. Shock was there, sir. But after initial fluid resuscitation, shock remained more or less. Improved.
Okay.
So what are the parameters by which you say the shock is improved?
One is that the CRT improved, sir, and urine output. Urine actually they are not giving any relevant history of decreased urine output. Post admission to here, actually while in a year itself, the child actually started passing urine. We were not able to catheterize or record the amount of urine and all.
So two adjuncts which has to be done along with intubation instead of pediatrics and adults also. One is G2
and Foley's.
In terms of shock, definitely you have to go for Foley's also. Fine.
So possible shock will be there, but post our initial resuscitation, child was actually improving, and our repeat ABG was showing a fall in lactate. Possible that initial lactic acidosis may be because of hypovolemia, sir. Since after fluid resuscitation it's started coming down, we hope that the shock is resolving. Possible diarrhea. I mean, there is no history of any diarrhea also. So vomiting, followed by we have to rule out any other metabolic causes is there.
Is there a possibility for toxicological cause also?
Toxicology causes also we have to keep in mind, sir.
Because everything, whatever you are saying is just acute and onset, isn't it?
Yes, sir. Toxicology causes also we have to keep in mind, sir.
Okay. So you have to send for toxicological sampling also, isn't it?
Yes, sir.
Fine.
Sir, or any sedative panel, everything we have to send.
Okay. Okay. Is there a possibility of a trauma here?
Initial
fall, maybe some height of like maybe 2 feet height or 3 feet height.
From our initial inspection, we couldn't find any evidence of fall or trauma or anything was there. From the history also, it was not there. But when child bringing in a very low GC, so we should also consider a possibility of any trauma also, sir.
Okay. Okay. So what are the current differential diagnoses which you will keep in your mind while treating this patient then? The patient is in shock, the patient is being secured airway also, because of metabolic acidosis. So what are the differential diagnoses which you will think about for this case?
First we have to rule out any first we have to treat the hypovolemic shock, sir. Shock possible due to hypovolemia, and since it's only 2 months, we should always consider the possibility of sepsis in this kind of pediatric age.
One more thing is just said about vomiting, isn't it?
Yes, sir.
How about the oral feeds?
Child was actually past 24 hours they are saying that because of vomiting, child feeding has been decreasing.
So that indeed can be a better cause for metabolic acidosis than just vomiting, because just vomiting won't cause severe metabolic acidosis. In fact, there should be signs of dehydration. The child may not be taking oral feeds. That is more of a cause which can result in metabolic acidosis, isn't it?
Yes, sir.
Okay.
One more thing is, sir, irrespective of difficulty in feeding over the past 24 hours, our initial GRBS was about 200. So possibility of diabetic ketoacidosis, type 1, everything also has to be kept in mind, sir, for our child. So we gave in the view of treated in the view of that a child having to rule out the cause of low GCS, to treat the diarrhea, and to treat the cause of severe metabolic acidosis. And for a child with a really small history, we'll have to go ahead with a wide workup for finding the etiology. And actually for our child subsequently, this child had severe coagulopathy, sir. The APTT was NCD, INR was around 3, fibrinogen was 50. So it's a broad options, sir. The why she child developed a coagulopathy, because we have to rule out, but sepsis markers were negative, but the cultures were still awaited. But with thrombocytosis, platelet was about more than 50 lakh. So child there is some errors in metabolism, something is there, sir, and her ammonia came to be 192. Ammonia was severely elevated, pyruvate was severely elevated, but several other amino acid levels were very below normal range. But RFT, LFT, these were within normal limits, sir.
Blood sugar and initial temperature.
Temperature was thyroid was within normal limit, and sugars were even though our repeat GRBS was also more or like 180 to 190 milligrams per deciliter, sir. And that was in lab lactate also we have sent, it was also elevated. Yes, sir.
Is there any significant head-to-toe examination findings?
Head to foot examinations, child look is absolutely normal grown for this age, sir. And there is no significant disproportionate growth differences or anything was not there, sir. Looked apparently grossly normal, sir.
Any significant birth history to be noted of?
No, sir. Birth history was also uneventful. And ultrasound abdomen was done from this child in PICU. Indeed, there was also no organomegaly, nothing. Abdominal ultrasound is also within normal limits.
Any family history of any sudden death
No.
or any infant death?
Yes, sir. One elder sibling of the child has similar episode of, but that at the age of 2 weeks itself, that child expired. The
Okay.
etiology is not known. This child has reached up to 2 months.
Mm.
So we have to suspect any genetic cause.
Okay. So any sort of system examination findings?
16, once the airway has been, everything has been secured, when we are able to properly examine it, the chest air entry was fine, sir, and no added sounds were there. X-ray also, we took X-ray, was also no opacities, nothing, it was absolutely normal. And per abdominal examination, abdomen was soft, not distended, not tender, bowel sounds were present. In detailed examination, USG was done, USG abdomen was also within normal cyst. CNS examination, initially in the pattern itself I have mentioned, sir, the patient was drowsy, so we already have an intubation. Post intubation, before shifting to the ICU, within that 1 hour span, the child actually didn't recover from any of our sedatives or muscle relaxer. The child was completely knocked out, and then respiratory system. CVS also, tachycardia was there. We were not able to appreciate any other murmurs, and the screening echo was also done from the ER side, sir, and it was normal for findings, sir. I mean, there is no pericardial effusion or any abnormal motion abnormality, nothing where we were able to appreciate, sir.
Okay, Dr. Manna, tell me about how you treat about pediatric shock in terms of cardiogenic shock, septic shock, and distributive shock.
Usually, fluid resuscitation we started, sir. In septic shock and all, we will be giving septic and hypovolemic shock. We will give 20 ml kg, 20 ml per kg is given. In cardiogenic shock, we don't. If at all, we don't. Usually, we prefer to give 5 to 10 ml per kg as the bolus dose. Then, if we don't know the cardiac status of the child, then we usually give 10 ml per kg as the
Over a period of
bolus
Bolus.
dose.
bolus. That is
Okay.
Followed by maintenance dose. And if we are giving bolus doses and if the child is responding to the fluids, we can give up to maximum 60 ml per kg.
Okay. So in case of traumatic shock, what's the PRBC dose?
PRBC is at 10 to 15 ml per kg.
10 to 15 ml per kg. Okay. Dr. Vivek, how do you treat pediatric hypoglycemia?
Sir, pediatric hypoglycemia usually.
First of all, what is infantile hypoglycemia?
Infants, sugar GRBS of less than 55 is hypoglycemia. In neonates, less than 45 is hypoglycemia. So, if you are giving in pediatrics, 10% dextrose is used. Dose is 5 to 10 ml per kg is given as bolus dose, and we have to reassess our sugar values after 1 hour. Then we have to plan whether patient requires maintenance dose or not. 25D usually in peripheral lines is not possible because of viscosity of substance.
Okay. Do you use isolate P in this case?
Sir, pediatric resuscitation only normal saline, sir. For maintenance we can use isolate P or half lines.
Okay. Is there any role for any first R antibiotic in this case?
For this child, actually we should go ahead with it because we don't know the exact etiology and possible chance of aspiration, and sepsis is always a possibility when we are getting a very even though it's not neonate, a 2 months old baby, we should always consider possibility of sepsis also, because in pediatric age group, child with sepsis may not show an initial increase in any of the inflammatory markers. So actually a possibility of aspiration and sepsis should be considered in this child, sir. Then we can give a shot of antibiotic also.
Okay, Dr. Vivek, so you have intubated this case. So once the intubation is done, you're going to shift to the ICU, isn't it? So there will be a time frame of like around 10 minutes, after which you will be shifting from the ER to the ICU. So what are things to be taken care of in that 10-minute frame which can end up in cardiac arrest?
Okay, sir. Before shifting the patient, we have to make sure vitals are stable before shifting out from here, sir, then crash cart should be ready before shifting the patient to ICU. And a person who is taking head and should hold the ET tube in the angle of mouth, and tube position should not be changed, and minimal motion or motion restriction of patient should be handled, sir. Then once the patient reaches ICU also, we have to make sure that all vital parameters are stable on ICUs.
Talking about taking care of the airway, what are things to be specifically taken care of?
The person who is taking head and should hold the ET tube at angle of mouth, sir, which will be already strapped with fixator, and patient should not hyperextend, or child should not be we should not hyperextend the neck, so that ET tube, there is chance of dislodgement of ET tube out. That should be taken care.
Okay.
Extension as well as flexion, both. See, flexion, what will happen, it will go little deeper inside. Main bronchus, any one main bronchus may be.
What are the possibilities by which you should suspect in this case? If there's a desaturation, what are the possible causes we should suspect?
If patient desaturation, we have to start from first our dopes. Displacement of tube we have to check, then obstruction, then position, and extubation. These are the 4 things we have to check for.
Pneumothorax. Okay. Is there by chance there is more possibility for children to have right side bronchus intubation than adults?
Yes, sir. It's more in pediatric.
Okay, because one of the most common cause of bradycardia, not arrest as such, bradycardia, one which we find is left side acute collapse followed by right side bronchus intubation, and then we'll have bradycardia. So we may not be able to, we may still get air sounds in the right side chest, but not in the left side. So we may be thinking like there is no displacement, there is no pneumothorax, but what is the subtle finding which you will get is left side of air entry is low and chest rise will be lower on the left side. So if you reposition the tube as you told, you will again get the best possible oxygenation available. So that should be always considered. Okay. Anything else? Anything targeted temperature management for this done in this case?
For our baby, we didn't go for a targeted temperature management because child never went into cardiac arrest, sir. So usually when patient having targeted temperature management is given whenever the patient is having cardiac arrest, to go ahead with the proper cerebral protection, we used to go for targeted temperature management. Our child never went into cardiac arrest. We are hoping that the cerebral perfusion was never compromised in our child, sir. And
in our child, moreover, we have to prevent hypothermia with warm blankets, because shock we are expecting.
Exactly.
Then acidosis is already there. Then hypothermia will worsen those acidosis, and coagulopathy is also there.
Okay, fine. So, is there anything, how did you counsel the bystanders?
Bystanders, we said that you have brought the child in a very bad state, and in our initial examination itself, child is in an impending cardiac arrest state. So we will have to go ahead with the intubation, and our initial lab parameters are showing that child is having a very bad acid state, and the child will require ICU status, the child will require prolonged ventilation, and we also will have to find out what's the cause. The exact etiology is still not found, and the any time child can become bad, and possibility of cardiac arrest and CPR, everything, bad prognosis has been explained to the bystanders, sir.
Okay. Any questions?
Okay, good.
So for the viewers, can we have just a summary of the whole case scenario for the viewers?
Yes, sir. A 2-month-old baby was brought to ER, and our initial finding itself, the child is having, patient is drowsy, bradypnea, in shock, sir. And our initial resuscitation, we were unable to secure a peripheral line, so we go ahead with an intraosseous access. With intraosseous access, we were able to give fluid bolus and resuscitate. The fluid resuscitation were possible, and in your very low GSS and ABG showing severe metabolic acidosis and bradypnea, we did a rapid sequence intubation of the baby. So in such a way, we were able to secure the airway and breathing also. So we were able to secure the airway, breathing, and after fluid resuscitation, we were able to have a proper adequate circulation, and the mottling, everything started coming down, and we were able to resuscitate the child. The child was able, after that, having good pulse with good peripheral pulsation. CRT count started coming less than 2 seconds. Oxygenation was maintaining. Repeat ABG was showing a fall in lactate level, and pH has started improving. So this was our initial and exposure disability. We prevented hypothermia. Everything was given, sir, and this was our initial resuscitation, and on further evaluation, the child was found to have some coagulopathy with severe metabolic acidosis with the possible metabolic inborn error of metabolic acidosis, because the patient was having some amount of hyperglycemia that is not resolving, and with the ketones negative. So this was the initial impression, and the exact diagnosis is still not found. We were only able to resuscitate and shift the child to the PICU. Child is still ongoing in status quo and ongoing treatment, and exact diagnosis has not yet been made for the child.
Okay, so this sums up our pediatric case presentation. Looking forward to more videos. Thank you for your patient listening.